Welcome to Dr. Balga's podcast for the Curious Doc. Today is 7th April 2026. This video is on a JACC article just accepted and published online on yesterday, 6th April 2026. It's an expert consensus document, free access, titled Master Athletes with Abnormal Cardiovascular Findings, a clinical consensus statement of the European Association of Preventive Cardiology of the ESC and the American College of Cardiology. What defines a master athlete? Individuals above the age of 35 years engaging in high-level training beyond standard recommendations. Do they have lower cardiovascular risk? Overall mortality is lower, but specific cardiovascular abnormalities may be more prevalent. Which abnormalities are common? Atrial arrhythmias, coronary calcification, aortic dilatation, and myocardial fibrosis. Does fitness eliminate disease risk? No. High fitness does not exclude cardiovascular risk or disease. Why are guidelines limited? Most data derive from sedentary populations, limiting applicability. What is the key clinical challenge? Balancing exercise benefits with potential cardiovascular risk. How should decisions be made? Through shared decision making, incorporating risk, symptoms, and athlete goals. Are symptoms reliable? Symptoms may differ or be blunted compared to sedentary individuals. Why do wearables play? They provide additional physiological data for assessment. Is management standardized? No, often based on expert consensus and limited data. Should risk factors be treated? Yes, similar to general population with guideline-based therapy. Role of statins? Primary therapy in elevated coronary calcium scores. Why is coronary artery calcium important? Intermediate or high-risk athletes may benefit from coronary artery calcium assessment. Is routine coronary artery calcium screening recommended? No, not in low-risk asymptomatic athletes. Does exercise replace medication? No. Exercise complements but does not replace pharmacotherapy. Is exercise restricted with coronary artery calcium? No restriction if asymptomatic and no inducible ischemia. Does fitness modify risk? Yes. Higher fitness lowers risk across coronary artery calcium levels. What about high coronary artery calcium above 300? This is associated with high event risk. Aggressive risk management is needed. Use of aspirin, reasonable in high risk plaque or elevated risk. Are risk scores accurate? Limited, may not capture athlete specific factors. What arrhythmias are common? Atrial fibrillation and exercise related ventricular arrhythmias. Why arrhythmias increase risk? Chronic high volume exercise may induce structural or electrical remodeling. What is myocardial fibrosis? Detected by cardiac MRI, gadolinium enhancement, possibly from repetitive cardiac strain. Is aortic dilatation seen? Yes, particularly in endurance athletes. Are they always pathological? Not always. Clinical context is critical. What guides prognosis? The type of abnormality, symptoms, and overall risk profile. Is lifelong exercise beneficial? Yes. Benefits generally outweigh risks. What is the key principle? Individualized assessment over blanket restriction. What is a major research gap? Lack of randomized trials in athletes. Future directions, registries, and longitudinal studies to define risks and outcomes. This ACC document reminded me of an editorial published way back in 2013, co-authored by Chip Levy from Auctioner, titled Run for Your Life at a Comfortable Speed, Not Too Far. But the background and concept is moderate exercise is one of the most powerful cardioprotective interventions, reducing mortality by 40% with 30 to 50 minutes per day of vigorous activity. However, beyond the sweet spot, benefits plateau and may reverse. Key mechanisms: extreme endurance exercise greater than 1 to 2 hours repeatedly over years leads to atrial and right ventricular stretch, resulting in microinjury, myocardial fibrosis, resulting in an arrhythmogenic substrate, increased coronary artery calcification and vascular stiffness, elevated catecholamines and oxidative stress, leading to inflammation. Clinical signals: fivefold increase in atrial fibrillation in veteran endurance athletes, higher plaque burden versus sedentary controls despite fitness, transient biomarker rise, troponins BNP after prolonged exercise. The U-curve insight: too little exercise, disease; moderate exercise, longevity; extreme exercise, potential harm. The key takeaway: the dose makes the medicine. Train enough to thrive, not enough to scar. Podcast brought to you by masterbedfacts.com. This podcast is for physicians and healthcare providers. If you enjoyed this video, please like, subscribe, and forward to your friends.